Yes, so my name is Shane Gallagher. I'm a psychiatric nurse practitioner by training. I'm a co-investigator on this study and also a research clinician at NYU, where I spend about half my time. The other half of my time, I'm at Bellevue Hospital as both a clinician and an associate director of the Nocturnus service for the inpatient units and consult service. So as you can see, we're going to talk today about navigating logistical barriers and post-discharge care linkages. Just to reiterate what we've been saying, if you could please just type your name, facility, and role in the chat box, that attendance will allow you to claim CME credit later. For this presentation in particular, I know we always say please participate and shout stuff out. For this one in particular, it will be helpful though, because this audience represents a pretty diverse bunch of catchment areas throughout New York. And so the info that I have, we compiled some good resources. They tend to be a bit general. So if you have any others you want to share, that'd be great, because as we'll see shortly, sometimes there are some barriers to navigate when discharging patients on MOUD. Just remember to keep things confidential. There's no stupid questions. We'd love to hear from you, either in the chat or speak up. And just a reminder also, the next lecture 2 weeks from today on Wednesday, April 20th, will be our final lecture, and we're going to talk about harm reduction and overdose prevention. It'll pick up and dovetail some of the info that we covered last time, and we'll share some cases as well. So the objectives today, we're going to describe the addiction care continuum as outlined by the American Society of Addiction Medicine. We'll outline best practices for hospital-based providers to link patients to outpatient care, as well as continuing MOUD if they've started in the hospital or they've been on maintenance. We'll talk about some specific issues and challenges related specifically to buprenorphine, as well as methadone, and how to navigate OTP or chemical dependency referrals. We'll also learn some strategies to address common logistical barriers related to OTPs, pharmacy, insurance, legal regulatory issues, as well as skilled nursing facilities or subacute rehabs. So community resources. You may hear the term a lot in inpatient about kind of escalating levels of care. So we'll familiarize you now with what are the ASAM criteria, the American Society of Addiction Medicine, kind of how they conceptualize the spectrum of care for substance use treatment. So at a glance here, these are kind of the 6 dimensions of assessment. So dimension 1, you want to address any acute intoxication or withdrawal potential. So when you're assessing this, you want to explore both the individual's past experiences, but also currently. So if the patient's currently intoxicated or having active withdrawal symptoms, you want to familiarize yourself with what these different toxidromes look like. We've talked about in the past, the clinical opioid withdrawal scale, or COWS, is the gold standard for addressing opiate withdrawal specifically. Dimension 2 are biomedical conditions and complications. So you want to explore an individual's health history, if they've been kind of keeping up with regular health maintenance, and if they're using intravenous drugs, offering them testing for infectious diseases like HIV or hepatitis C and linking them to treatment. Third are the emotional, behavioral, and cognitive conditions and complications. So you want to explore what some of the triggers, what are some of the environmental contexts that are perpetuating the patient's use, and screen them for possible comorbid psychiatric conditions may or may not be influenced by their substance use. Dimension 4, readiness to change. So you may hear people say pre-contemplative, contemplative maintenance, the classic Prochaska, Di Clemente stages of change. And also, if you're familiar with some of the motivational interviewing techniques, this is kind of that stage, seeing where the patient is. So, you may encounter a patient who doesn't necessarily want to stop using on the encounter you see them. And there are still interventions and high yield that you can have, especially with harm reduction, which we'll talk about next week. Dimension 5 is kind of in that remission phase. You want to explore possible vulnerabilities to relapse, and if the patient is continue to using or having risk factors, how to mitigate those. So connecting them to needle exchanges, giving them naloxone kits, and so forth. And then last, in the phase of recovery, kind of helping the patient contextualize that journey, link themselves to community resources, and understanding that when they are seeing you, the provider, that it's kind of a safe, non-judgmental context for them. So this is that model I was just referring to in regards to the ASAM continuum of care. So here we at 0.5, we have early intervention. So if you heard of SBIRT, this is kind of that model for screening, brief intervention, and referral to treatment. And 1 would be outpatient services. So this would be the lowest, kind of least invasive, more simple level of care. And then we come up to level 2, which would be intensive outpatient, partial hospitalization. Next would be residential or inpatient services. And you can see they specifically indicate that these are low intensity residential services. So the patient is relatively medically stable, and any comorbidities they could have managed as an outpatient without any type of higher intervention. And then there's also clinically managed population-specific high-intensity residential services, as well as long-term high-intensity. And then here, so 3.7 to 4 is kind of where most of you probably land. So if you're in an inpatient medical surgical context, that's going to be medically managed intensive inpatient services. So it's saying that the patient has medical needs that need to be monitored 24 hours a day. On this next graph here, you can kind of see as you go up the levels of care 1 through 4 here, like outpatient, you would have minimal to no risk of acute withdrawal syndrome. You could escalate to intensive outpatient if there's minimal. Mild to moderate, you may want to have more of a monitored setting. But if there's severe concerns, say if the patient is also using benzodiazepines or alcohol withdrawal, and there's concern for seizure or airway protection, this would be a more medically managed inpatient setting. You also hear, these were what I was just talking about in terms of stages of change. So if a patient is referred and presenting to outpatient, they're probably, hopefully they're at action, but they may kind of be later preparation action, and then you're trying to establish that maintenance. This is an interesting kind of point here, maintains abstinence. In some settings, it may be, but in a lot of settings, the patient may have some continued use. So that's something you kind of keep an eye on. Whereas a monitored inpatient setting, the patient's having no success with able to stopping. So you may want to do a detox or taper type intervention. So some questions to ask yourself when you're thinking about what level of care is appropriate. Who on the care team at your hospital is typically assessing the patient for post-discharge addiction needs? So is it the primary clinician or provider, or is it only social work and case management? Are there peers or KSACs, so drug abuse and alcohol counselors, or other provider types in your hospital? And then what is the role of the primary provider or clinician? Can they provide a buprenorphine bridge prescription on discharge? Some of you may be familiar with the locators software that social workers, case managers use. So that you collect demographic and clinical information, you plug it in, and it will actually use an algorithm to tell you what level of care is most appropriate for the patient. Then you want to think about what community partners do you already have. So I know it's some of the sites that you're affiliated with in the crowd have internal resources, either a chemical dependency program, addiction prescribers and providers in some type of outpatient setting, either psychiatry or medicine, and or an opioid treatment program or OTP that can offer daily methadone dosing. So for which levels of care do you need to build connections? So maybe your inpatient team doesn't have a great rapport with an OTP. And so are you only referring patients to detox, which may not necessarily be kind of congruent with the patient's goals and what they're looking for at that time? When you want to make a referral, is there a shared list of resources and contacts available to all staff? Are there any warm handoff protocols during hospitalization, or are patients given a phone number and pamphlet and told to call themselves? And then this is a question to the crowd, if anybody has thoughts. What do you think would be the ideal answer to some of these questions, and how can we get there? Does anyone want to share what the referral process kind of landscape looks like at their facility? Do you use a warm handoff? Do you have connections to OTPs or buprenorphine providers on discharge?
At Maimonides, I think the inpatient services use primarily the social work and case management model for discharge planning.
Yeah.
Not the best person to answer this question because I don't work on the inpatient service, but
Sure.
That's my impression. We unfortunately have very few inpatient waivered providers. There are some. We're trying to get more people waivered at the same time that we pressure the United States government to eliminate the waiver requirement. And we have a clinic on campus that can follow discharged patients who are felt to need ongoing buprenorphine therapy.
So thank you for that. So yeah, it sounds like at your site, social work takes on a lot of the responsibility, which is pretty common at the hospitals I've worked at. It's been kind of a similar thing. It sounds like you do have a warm handoff process, which is nice. It helps kind of if you're on the inpatient side with follow-up. On a team I worked on, it was nice because we could kind of help the patients troubleshoot, and we could also see if they were making appointments or how we could better help them. Anyone else want to jump in on what the referral process looks like, what the ideal situation would be, some of the challenges? All right, we can keep going. Maybe they'll come up when we hit different points. So the next couple slides are going to iterate with some data that MOUD is the best treatment for reducing morbidity and mortality. It's something that I've kind of actually learned recently. When I was being trained on addiction treatment, the term or acronym that we always would use was MAT, medication assisted treatment. And we're kind of shifting more to MOUD, medication for opioid use disorder, because in and of itself, prescribing a medication and having that rapport with the patient is treatment. And as we'll see in just a moment, it's kind of the gold standard and the best treatment for preventing overdose and death. So you can see here, this is a study from 2020 by Wakeman et al. The adjusted hazard ratios for overdose and serious opioid-related acute care use compared to a group with no treatment. So at 3 months and 12 months, you can see the no treatment hazard ratio of 1 for reference. Inpatient detox or residential, 0.82 and 1 respectively, and intensive outpatient, 0.81 and 0.75. And then you can see here this dramatic reduction. So if there's MOUD treatment with buprenorphine or methadone, significant reduction at the 3-month and 12-month benchmarks. And MOUD treatment with naltrexone, 0.59 and 0.73. I believe there's they also use the PO formulation, because this confused me because I was thinking initially they may have been giving the intramuscular and why there wasn't more of a reduction, but it was also because they offered PO option. But you can see here offering medication is a major reduction both in morbidity and mortality for folks with opioid use disorder. And then this is a graph, same kind of data, graphical representation here. At the top, you can see the outcomes are significantly improved with MOUD with buprenorphine or methadone compared to kind of all modalities here. And then the bottom line is going to be no treatment. And then this is at a 6-month follow-up with the cohort there. So detox alone does not usually lead to remission of OUD and should not be the default offering. There are some folks, in emergency or acute settings who will say, go to detox and kind of get the substances out of your system. But there's a study here we have from Morgan et al. Detox is often a revolving door, they call it. 61% of inpatient detox admissions resulted in a subsequent detox admission without progressing to further inpatient care. And it rarely leads to long-term residential treatment referrals. As you may know, the risk of overdose after detox is increased because the patient has cleared opioids out of their system and now has a decreased tolerance. So if they go back to patterns of use that were similar to before, they can be at increased risk of overdose. So detox does not replace starting MOUD, nor will it resolve MOUD. So if indeed you are referring a patient to detox, it would be appropriate at that point to start them on a medication, and you can have a warm handoff, and the providers there can decide if a taper or maintenance is the appropriate move for the patient from that point. So review of the evidence for residential treatment. There's combined evidence from 8 reviews and 21 individual studies. There are 2 randomized controlled trials, but some of the methodological weaknesses include they exclude individuals by their appropriateness to residential treatment, so to speak. So there's a lot of exclusionary criteria. For those of you who work in med-surg settings, I worked as an addiction consultant, and it is true, if the patient has any type of acute medical needs, it will often exclude them from being admitted to residential treatment. And some residential treatment paradoxically won't always necessarily offer methadone, for example. They'll only offer buprenorphine and so forth. There was a high rate of confounding variables, high dropout rate in the population. Most of the studies have limited generalizability. And there was conclusion for moderate evidence. Most studies showed some positive effect, although other studies showed no difference for residential treatment. So kind of mixed evidence with some methodological weaknesses there. So impact of residential treatment. Some studies showed decreased days of drinking or low addiction severity index. So decreased cravings or decreased risk-taking behaviors, decreased overdose. Some improvement in housing for individuals who are homeless or unstably housed. Improvement in quality of life and psychiatric symptoms for some of the dual diagnosis patients. For example, some studies found that there is decreased incidence of suicidal ideation. But again, in note, many studies had no main effect from residential. So readmission rates with residential, a study of 10 states Medicaid claims looked at the 90-day readmission rate after hospitalization or detox, and decreased risk of readmission by 50% for those who were in residential within 14 days of discharge. This was found to be similar to the impact of just starting a patient on MOUD, so buprenorphine, methadone, or naltrexone. However, only 3 of the states were included when they did analyses of residential treatment. So when you combine MOUD with residential treatment, only 18% of clients in the residential treatment programs had MOUD in their treatment plans, which I'm sure is a surprise to you. It sounds very surprising to me that not even 1 in 5 of the patients during their residential had MOD medication being prescribed to them. For the patients who were on a form of MOUD, it was associated with a 40% increased likelihood of short-term completion. So that means they were discharged within 30 days versus long-term, which would be 30 days, 6 months. These findings weren't consistent when researchers looked at long-term treatment. So while MOUD is helpful, it looks like these longer stays aren't necessarily more helpful than an outpatient program. And when we look at residential treatment, MOUD, and mortality, so compared to no treatment, MOUD, residential, or combination, improved outcomes, meaning decreased mortality, reduced compared to no treatment. The adjusted hazard ratios compared to no treatment for all-cause mortality. So you can see, again, MOUD outperforms residential, whereas there is kind of an incremental increase if there's both MOUD and residential. Keeping in mind that it's short term, so these less than 30 days, it doesn't seem like adding a long-term stay provides much of an improvement there. This is a note here because patients often do ask me, both in inpatient and outpatient settings, if they should pursue abstinence, especially if they're in a Narcotics Anonymous group that's promoting abstinence, doesn't want them on MOUD. And I usually will discuss with them the risk of an abstinence-based treatment model. So in this study, there were 276 patients with drug use followed for 8 years after their engagement in abstinence-based residential treatment. And you can see there was over 15 times the risk of death in the first 4 weeks after leaving residential, giving us a pretty salient reminder of the importance of MOUD, at least in early recovery. So if you go back a few lectures to our diagnosis of OUD, the patient will be classified as opioid use disorder in sustained remission after a year. So I usually give the patient that kind of benchmark. Let's see if you're starting MOUD, how you're doing in a year. You check on them kind of in 3-month intervals. Of course, if you're starting someone on buprenorphine, you're likely seeing them weekly, monthly in the beginning. But certainly in that first year, I really emphasize the risk, especially because there's such a pronounced risk of overdose and death that's been replicated in so many studies for folks who are just getting out of these treatment programs.
Shane, there's a question in the chat from Janet about any data regarding residential treatment for women with newborns or during pregnancy, or if you have any comments on that.
That's a really good question. The studies that we looked at in this slide deck didn't specifically look at that. But again, that in the methodological weakness part, I know that sometimes, I mean, if the woman had an uncomplicated pregnancy, it probably wouldn't exclude them. But if there was a complicated pregnancy, that may be something that would exclude them. But that's something worth exploring. I don't have a comment specifically on if there are nuanced differences for that population. Good question. All right, so in regards to best practices, so some of the key things in reference to what we talked about, the ideal situation. So building strong cross-institutional relationships is very important. Buy-in from all levels of the institution. So someone had shared earlier that if there's not a whole lot of X-waivered providers, it's not kind of in the culture to start buprenorphine, whereas say a methadone taper is preferred. That could be something that could be worked on kind of at different levels of stakeholders in the institution. And also having a strong foundation outpatient. If there's a dearth of internal resources, it's good to build relationships with some outpatient addiction providers. If you want to even become an outpatient provider yourself, it's definitely easier now to become waivered. On the next couple slides, I'll talk about a notice of intent. So there's kind of this accelerated process. If you want to start prescribing buprenorphine, you can even bypass the course that used to be required. But on that note of building foundations, if you are part of a group, or say you're a hospitalist and you're seeing a lot of patients in this population, having someone on your team who's involved in the discharge process and referral process, kind of familiarize yourself with even like 2 or 3 clinics or programs. It's helpful to know because you can just get a sense of their bandwidth. Like I know for those who are located in New York City, there are quite a few OTPs and chemical dependency programs, but it's nice to know what their bandwidth is. Sometimes they're, Some clinics have a lot of availability, some have less. So it's good to kind of know what the landscape looks like there. So on this note, developing and maintaining a referral list. So developing an up-to-date list of community resources to ensure linkage. Ideally including contact names, addresses, phone numbers, and so forth. I did actually find this for you guys as kind of a cheat sheet. It'll come up in a couple of slides. It's an Oasis resource. What's helpful is it has program directors' names and an email and phone number for them. And if it's like a tricky hospital kind of dial your extension, it even has people's extensions, which is, I know personally, is very helpful, because sometimes you call up against that general hospital or clinic number and it's like you press 5 numbers and then end up getting a voicemail. So types of contacts include, you want to know buprenorphine providers, and depending on where you're located, you can kind of think outside the box. Sometimes a lot of chemical dependency psychiatry based programs will have prescribers, but also some primary care groups will have them, or if they're freestanding addiction clinics, of course, OTPs, and then residential programs. So think about what resources are already known to your group or institution, what connections exist, and how to build on those. If the patient has an existing relationship with provider or site, contact them first. So when you work with this population, if it's probably built into most of your assessments, but if it's not, getting a pretty thorough treatment history. If you ask the patient, how many times have you been to detox rehab? Have you tried anything outpatient? I picked up a bunch of referral connections and resources from patients. Actually, they'll tell you, and I find they're usually pretty honest about where they had a good experience or where they had an easier chance getting accepted, what kind of resources they offered, and so forth. So sometimes they can be a very valuable asset to your team as well. In establishing and maintaining these relationships, as you all know, we have a pretty limited window to link patients to outpatient services. So successful referrals require robust relationships in the community, often with significant planning. If there are any social workers in the audience, you know that say you want to get a patient into a rehab, the referral process is quite cumbersome. So submitting that paperwork and working with the patient can take quite a bit of time, especially if you want them to get accepted and transported from. You often need more than a couple of days, which are some of these, average length of stays for this population. Given the high turnover in the addiction field, these relationships require continuous attention. So consider site visits, or in our current climate, maybe Zoom or face-to-face meetings if you can. So direct linkage is best. Patients who are admitted with opioid use disorder, even if it's not directly related to their opioid use, this definitely is a reachable moment to engage them, to kind of keep that conversation open in a very kind of non-judgmental, see where they're at phase, rather than you need to stop, or having kind of a paternalistic approach. You don't want to risk undoing the progress achieved during the hospitalization. So if you did get them on some form of MOUD, it would be a shame to have them be discharged, say, on a weekend and have nowhere to go, nowhere to obtain medication. Directly admitted patients are equally successful in treatment. And as we know, there's quite a risk of morbidity and mortality if a patient's not linked and maintained on medication. So inpatient hospitalization reduces some barriers to treatment entry. As we know, they're monitored for 24 hours. They have access to some form of MOUD and can be stabilized on a dose, can be escalated as needed. EKG access if the patient started on methadone, and they can co-manage and stabilize other acute illnesses. I work in an outpatient addiction setting now. I previously worked inpatient, but it's very helpful to me. I have some patients who have a lot of difficulty maintaining some level of abstinence and getting to the point where they can be induced on buprenorphine. So it's like a gift to me when an inpatient provider has induced them already and they're already on a stable dose, so that when they come to me, I can continue it. And we're kind of already there. Because I've seen the other side where it's difficult for patients to tolerate an office-based or home-based induction. Benefits from the patient perspective. There's no need to wait for an intake. I'll caveat this with, I know because some clinics in my area do have a wait. So if you can provide them with a bridge prescription, it can be very valuable. But at least then they'll have some way to access medication. This is what I was just saying at this point, no need to present in withdrawal for medical intake appointment. And I've actually found recently, kind of a side note, patients who are opioid and methadone negative on their urine screen, my clinic screens for fentanyl, and we've actually had patients even 2-3 days out with a fentanyl positive urine have some level of precipitated withdrawal, which is its own kind of issue to navigate in the clinic. So if they can be induced in a monitored setting, again, it's very helpful. No need for them to arrange childcare or issues with their job while they're in withdrawal, and no need to experience the discomfort of a slow induction process. So what is required for direct linkage? Obviously, a direct contact person at the clinic, and then clear admission criteria and protocol. Helpful if you have rapid closed loop communication, again, especially with short inpatient stays. So if your patient's going to be admitted for a relatively uncomplicated issue, 2 or 3 days, it's good to have a clear time and date that they can go to present for intake. We'll get to issues with methadone. Often methadone programs do have more of a walk-in process, so that kind of is its own unique challenge. But if you can even identify clinics that have open slots, so the bandwidth, and when is the best time for them to present for intake. Often it's very early in the morning. It's usually like 7 to 9 a.m. So that's just something to flag. Often when you're discharging a patient, we all know, like, realistically, they're not going to be discharged that early. So maybe planning in advance, discharging them the day before, giving them a dose so that they can present the next day early in the morning. Start methadone or bup in the hospital. Yes, you can. Starting in the hospital is both legal and advisable. And according to Title 21 of the Code of Federal Regulations, CFR, you can see this section is not intended to impose any limitations on a physician or authorized hospital staff to administer narcotic drugs in a hospital, maintain or detoxify as an incidental adjunct to medical or surgical treatment. I think there's another slide coming up on this. In the past week, in preparing for this lecture, I did kind of look up more about, some of you may or may not be familiar with the 72-hour rule. I think, oh, here we go. It's on the next slide. So prescribing on discharge, we know you cannot prescribe methadone on discharge. Very small asterisk to that. If you are a pain, palliative, or oncology prescriber and you're prescribing it TID for some type of intractable pain, different story. But for this population, prescribing it as MOUD, there are federal restrictions. So it would have to be done in an OTP. You can't give an outpatient prescription. However, prescribing buprenorphine, the provider does need to have an X waiver. As I was saying, now all providers can provide buprenorphine for up to 30 patients, but you do need to go onto SAMHSA and give a notice of intent that you do plan to formally get X waivered and complete the process of taking the 8-hour class in some time frame. Here, the 72-hour rule, which allows MOUD to be given in emergency and acute settings. And this may include dispensing methadone from EDs and usually med-surg, actually. But so I was looking into kind of the genesis of this rule, and there actually is a statement from Oasis that they, I've never seen this happen, but it is, if a patient Googles it, there is a statement from Oasis where the Greater New York Hospital Association, CEOs of hospitals agreed that patients should have access and shouldn't be denied buprenorphine. And so the patient can actually present this, like the letter or information that if they do want to start a buprenorphine induction while admitted, they should be able to, or at least say for some reason it wasn't on formulary at your site, that you should explore some avenue or channel for them to get this. But for residents or non-ex-waivered folks in the crowd, if you're not as familiar with prescribing, I encourage you to discuss with your colleagues some kind of tips and tricks, watch our lectures even, because you can prescribe buprenorphine for 72 hours under the hospital DEA. So you don't need it, the ex-waivered DEA of your own. You can give it for 3 days. This is especially helpful if you're working after hours and it's, say, Friday at 8 o'clock, and you're concerned about the patient having access to buprenorphine. The 72-hour rule obviously would cover you till Mondays, till someone could either prescribe a bridge prescription or you could do a direct discharge to a program. I can't see the chat, Noah. Is there any, I just want to pause for a sec. Are there any questions at this point?
Nothing so far, but if folks want to jump.
Cool.
Just comment that this is a very active discussion legislatively.
Yeah.
And just in the past couple of weeks, there's been some interesting announcements that have required a lot of clarification that has not been forthcoming. I'd be very cautious about giving people doses of methadone to go. Which is what you seem to suggest at in the very last line of that slide. That may be something that's going to be allowed, but the most recent guidance we've had from the DEA, as of just like 2 days ago, is that state law supervenes, and this is still very unclear about the legality of this. I'd be very cautious about it, even just not even considering the clinical aspects of giving out methadone. Just the legislative aspects, but certainly the 3-day rule for buprenorphine applies, and you should have a low threshold to either dispense or prescribe 3 days worth of buprenorphine, or even better, get waivered. You do not need to take any sort of course anymore. You can just fill out an attestation, and they'll send you your new DEA number with an X in front of it, and you're licensed.
And just to point out, yeah, that's right, Ruben. And also, I think there's a distinction between giving medication and prescribing medication. So there's changes where you can now prescribe through the 3 days, but dispensing, like for a patient who's in the hospital and providing them with methadone, is a different situation and is allowed. I'm putting some info in the chat. This is like a very active space, and things will probably change in the coming months, hopefully for the better, but stay tuned. But I think, bottom line is, if you just get the X waiver, which you don't have to get trained for anymore, then you can ignore all of this like regulatory stuff and just prescribe to up to 30 patients.
Yeah, no, I appreciate that that comment on the nuance, because there are a lot of rapid developments. I would say kind of check also at your particular institution. Typically, the pharmacists are pretty versed on this, and your institution would also have to kind of get in step with that. So yeah, at this point, this is not to suggest giving a take-home prescription. It would just be for dispensing in the ED, yeah. So linkage to methadone afterwards. Patients desiring methadone maintenance should be directly admitted to clinic after discharge. Patients do have to sign a HIP release as well as a 42 CFR. There's an extra layer of protection for substance use treatment related information so that you can communicate with a methadone program. The hospital will need to send required documents to the clinic and be notified if the patient's accepted. Usually this includes, just kind of some brief information about the patient's stay, obviously a discharge summary. And usually I find the thing they want to know the most is like, when the patient's going to receive their last dose and what dose they were at. Unless they get enrolled while they're inpatient, which is a rare kind of occurrence, usually it's going to be 30 or 40 milligrams maximum. And patients should receive their dose in the hospital on the day of discharge and then plan to receive a dose the day after discharge at the clinic. So that's kind of alluding to what I was talking about before. Often methadone programs won't be able to admit and then administer the medication in the same day. So it's helpful to kind of give them their last dose and then planning for them to present to an OTP the following day. So some common barriers, clearly geography and transportation. In the beginning, methadone programs require daily attendance, so it sometimes can be a challenge for them, for patients to present daily. Kind of offset this, a lot of OTPs, especially ones I've worked with, they do have social workers and or case acts that can usually help them navigate this, whether it be giving them Metro cards or helping them set up transportation. But as we all know, sometimes setting up accessorized transportation so forth can be tricky. Simultaneous linkage to residential treatment. So this not only has the geographic challenge, being restricted from leaving a residential setting, not all settings offer both methadone and bupe, so that's something to research. Photo ID, this was an issue for a lot of patients that I saw. If they were undomiciled and had issues with things being stolen from them, they often wouldn't have an ID. So working with social work and case management here on finding a way for them to obtain temporary ID, because they will need ID when they present to an OTP. Prior burn bridges. So there is a software program called Lighthouse so that the OTPs are aware of when patients have been admitted to other programs. So just for an example, if a patient's currently admitted to an OTP and for whatever reason they want to switch, say it's geography or another reason, they will have to go to their other OTP or at least work with their new one to revoke their enrollment and then start a new enrollment. So there are some administrative barriers and issues that you can help the patient at least start initially exploring. So if there is a social worker case manager on your team, this is something that they can kind of help out with and help coordinate. Concerns about methadone programs, about concurrent medical issues. So say they're on QTC prolonging agents, or if they have active alcohol or benzodiazepine use disorders. So for folks who are inpatient providers, if your patient is on some type of benzodiazepine taper, if you're able to, completing it is ideal. If not, at least opening the conversation that the majority of OTPs on admission want the patient to taper. So at least opening the conversations that they're going to need to taper off their benzos or have a provider that's going to follow them very closely. So here are a couple of ways to overcome this. So like I said, signing patients up for transportation resources. So contacting their insurance company, seeing what may be available to them. Developing relationships with residential programs. There are some programs that will, if you can get a patient admitted to an OTP, they will actually pick up, they'll give pickups to a clinician from the residential program, either on a weekly or bi-weekly basis. So that's something you could explore if you want to discharge a patient to residential on methadone. Discuss with the methadone program other alternate ways of proving ID. They may be willing to accept them short term. Document in the medical record patient's motivation for treatment and other supports if they have issues with burn bridges. And also document your assessment on the risks and benefits of methadone for this patient, having a recent EKG and so forth. So here's an ideal admission to methadone clinic from the hospital. Patient enters the clinic in direct admission status, which is similar to guest or host dosing. Bypass the need to complete formal admission process and see empty prior to dosing. Although I can say from experience, this doesn't usually the physician will have to see the patient prior to dosing. But in some instances, if you do have a direct admission process, maybe it can happen. Typically, you complete the formal intake process over the first few weeks of dosing, and ideally start any day of the week. This caveat, though, I think in New York, for the most part, it's very rare, if ever, that programs are open on Sunday. They're usually open on Saturdays, but Sundays and holidays, you do kind of want to prepare accordingly. Often Saturdays, there are shorter hours too. So they may close between like 1 and 3 p.m. So it's something you just want to double check what the hours look like and let the patient know that they got to make it there if they want to get dosed that day. Methadone 101. As we said, outpatient, the fixed starting dose is 30 milligrams. Can give, excuse me, additional 10 to go up to 40 if doing a second formal assessment. Titration schedules are often set by the individual clinic or hospital and are often slow. They're usually like 5 milligrams or so in a week. Patients may get automatic decreases for missing multiple days in a row. And all this means that patients may struggle to get to and stay on a therapeutic dose. Methadone maintenance is a highly structured intervention and modality. They see a nurse daily. They have weekly individual and group counseling. There are random supervised tox screens. They have oversight from the medical director. As you know, dosing is observed until usually there's a time frame that if they're coming in every day, taking their dose, having appropriate tox screens, they can get take homes weekly, sometimes even monthly. As mentioned, limited hours. So they're often, most of the ones I know are closed by 3. I think some may stay open until 5, but they're usually open early and closed pretty early. There often are a mix of stable and then newer, less stable patients. Some patients feel that it's a lack of privacy or there's stigma associated with going. Sometimes there's the frustration of a separate system so that they can't get a one-stop shop primary care there. Again, limited access and far travel with geography. And this perception of no ability to graduate, although I will say there are often ways, a lot of OTPs will do BUP inductions, and then they will kind of do warm handoffs if they think a patient's stable and appropriate for a less intensive outpatient model. So I would say that you can kind of dispel that myth that they'll be involved in an OTP forever. There are ways to kind of transition once they're stable. So how to earn take homes, if you're interested, this is the 8-point criteria. Absence of recent drug use. I won't go through all of them. I'll let you kind of see those. We'll send out the slides just in the interest of time. Linking to BUP, if BUP or naltrexone is recommended, the patient should be scheduled at a clinic so that they can continue and try to schedule directly from the hospital. Ideally within 1 week. Realistically, there may be more of a wait. So giving them a bridge until they can get to their appointment. When to follow up, the sooner the better. A study here shows patients with same day or next day appointments were 2.6 times as likely to attend their follow-up compared to patients who are given an appointment 2+ days out. What if an appointment cannot be made? Providing a bridge prescription days to weeks to a patient may still be the best option. Continuing BUP allows the patient to not experience cravings or withdrawal, obviously not relapse, focus their energy on attempting to access care themselves now. And this may be a good option for patients who desire methadone but cannot be linked. At least if they have a short buprenorphine bridge, they'll have something so that they don't have to use illicit drugs. So addressing some barriers. So pharmacies may limit access to buprenorphine because of stigma, concerns for DEA investigation, distrust of clinical prescribing. About 30% of pharmacies report limitations to filling prescriptions. rural communities having even more issues with this. 1 in 5 individuals who attempt to fill a prescription are faced with some type of pharmacy barrier, whether it be prior auth. I know some, like insurances, will only cover certain formulations. The local pharmacies may not have them. And so insurance companies can impact timely access to the medication. If this is happening, you may need to document a medical necessity, complete a prior auth, which is of course timely. There may be failed first attempts, as we said, formally restrictions, and then also insurance-based restrictions on treatment duration. So how long of a supply you can write for. Overcoming these, partner with hospital-based pharmacists or pharmacy tech to help streamline these prior auths or barriers, and collaborate with some local outpatient pharmacies to discuss best practices. Sometimes, I know personally, sometimes if you're looking at a lot of the larger retail pharmacies in the area, sometimes going to smaller pharmacies that are kind of used to dispensing this medication can be another option also, if you've kind of exhausted other resources. Discharging patients to skilled nursing. So as we've said, patients to OUD under kind of these new legal guidelines, they have the right to access medical care. And it's found that there's been discrimination allegations at SNFs for patients with OUD. So it's explicitly a violation of the ADA Act for SNFs to not take patients due to SUD diagnosis alone or being on MOUD. However, patients in this population continue to face discrimination. 81% of SNF referrals were rejected for patients with MOUD. 15% were noted to be explicitly discriminatory. For those who are used to making these referrals, it is often an issue of they don't carry the medication. So say you have a patient who it's contraindicated to give them methadone and they're on bupe, the facility may not carry bupe or be willing to give bupe for the time duration that you're able to prescribe. So this is where it's helpful to kind of, learn the landscape of some of the SNFs and SARS in your area. Additional resources. I've talked about the NOI. So this is, if you're interested, please check out the SAMHSA website. This goes into more specifics. We're going to send out these slides so you can kind of follow these steps if you're interested in this alternate pathway with the notice of intent. I'm going to go through a couple slides with resources, but I really want to highlight this one as like an excellent resource. It's called the Provider Clinical Support System. So pcssnow.org. You can get a mentor to help you support prescribing and get access to kind of a clinician to clinician warm line. This is another, if you want to set up on a more organizational level, this is a resource to set up teaching and technical assistance through OBAT. There's the website there. If you Google ECHOs, there are these extensions for community healthcare outcomes. They have them in all different types of clinical disciplines. There's also a national clinician consult warm line, links down at the bottom there if you're interested. A couple of resources in New York, the virtual bupe clinic through New York City Health and Hospitals. So this can expand access if your patients aren't able to present to a clinic. They can do a virtual option. Phone number and website are there. This is that website that I was talking about that gives you, if you type in your zip code and info, on this, I was trying this yesterday. You want to click the top one because this is a prevention program. You want to click on treatment programs, but it will give you names, emails, so forth, telephone numbers for resource in your area. NYC Well, excellent resource for substance and psychiatric resources. I don't think we have time to highlight. I know the team from Reach in Ithaca, but if interested, we can get you more information on that. There are some private telehealth companies. Some of your facilities have relationships with these, but these are the websites if you're interested. In conclusion, understanding the referral process and recognitions is big. Try to develop and maintain a list of resources. Work collaboratively, providing bridge prescriptions if you can. Some acknowledgements. Before we do questions, I'll just pass it over to Aditayo to talk about CMEs real quick.
Cover this quickly. Adetayo is sharing this information in the chat as we speak, but basically we just wanted to highlight that you may not automatically get sent a certificate when you claim your CME credits. What you need to do if you don't get the certificate is you have to log into the CME tracker to access your transcript. And the link is here in the slide. And then also Adetayo just put it in the chat. And also a note that credits, unfortunately, are only available to physicians, nurses, and physician's assistants, because that's how the CME course was set up. And also, when you log into this tracker, you'll see that the series is titled "Regional Approaches in Tertiary Care." So just so you're not surprised, that is what this series is called for official CME purposes. So yeah, check out the chat for the CME link for today and for this tracker website.
Great. Thank you, Noah, and thank you, Shane. I think we will, since we're right at time, maybe our team can stay on for another few minutes if folks have questions. But also know that we're going to send out the recording of the lecture, plus all the slides, including the ones that we had to breeze through quickly, because there's a lot to cover today. And our next lecture, which is our last lecture in 2 weeks, we will also give a quick overview of the study and hopefully give a chance for the leads at the different hospitals to introduce themselves on that meeting. But we're at time, so you're free to go now, but we will stick around.